This recording will go over polycystic kidney disease. Polycystic kidney disease, or PKD, is a genetic disorder in which fluid-filled cysts develop in the nephrons. PKD is associated with hypertension, abdominal fullness and pain, episodes of cyst bleeding, hematuria, kidney stone formation, infections, and systemic disease. The cysts look like clusters of grapes. Over time, growing cysts damage the glomerular and tubular membranes. Each cystic kidney enlarges, becoming the size of a football, and may weigh 10 pounds or more. As cysts fill with fluid and become larger, kidney function becomes less effective, and urine formation and waste elimination are impaired. Most patients with PKD have high blood pressure. The cause of hypertension is related to kidney ischemia from the enlarging cysts. As the vessels are compressed, blood flow to the kidney decreases, and the renin-angiotensin system is activated, raising blood pressure. Control of hypertension is a top priority because proper treatment can disrupt the process that leads to further kidney damage, as well as avoid complications such as stroke from hypertension. Cysts may also occur in the liver and blood vessels. The incidence of cerebral aneurysms, outpouching and thinning of the arterial wall, is higher in patients with PKD. Aneurysms may rupture, causing bleeding and sudden death. For unknown reasons, kidney stones occur in many patients with PKD. Heart valve problems, left ventricular hypertrophy, and colonic diverticuli also are common in patients with PKD. There is no way to prevent PKD, although early detection and management of hypertension may slow the progression of kidney damage and impaired elimination. Genetic counseling may be useful for adults who have one parent with PKD. Family history analysis is used to help identify people at risk. Because PKD is a chronic disease with periods of acute problems, most management occurs in the community rather than in acute care hospital. In terms of assessment, explore the family history of a patient with suspected or actual PKD and ask whether either parent was known to have PKD or whether there is a family history of kidney disease. Pain is often the first symptom of PKD. Inspect the abdomen. A distended abdomen is common as the cystic kidneys swell and push the abdominal contents forward. Polycystic kidneys are easily palpated because of their increased size. Use gentle abdominal palpation because the cystic kidneys and nearby tissue may be tender and palpitation is uncomfortable. The patient may also have flank pain as a dull ache or as a sharp and intermittent discomfort. Dull, aching pain is caused by increased kidney size with distension, abnormal stimulation of sensory neurons in the kidney, or infection within the cyst. Sharp, intermittent pain occurs when a cyst ruptures or a stone is present. When a cyst ruptures, the patient may have bright red or cola-colored urine. Infection is suspected if the urine is cloudy or foul-smelling, or if there is dysuria. Nocturia is an early symptom and occurs because of decreased urine concentrating ability. Patients with early PKD often have hyperfiltration leading to wasting of sodium and water, which disrupts fluid and electrolyte balance. Later, as kidney function declines, the patient retains water and sodium, causing hypertension, edema, and uremic symptoms such as anorexia, nausea, vomiting, pruritus, and fatigue. Because intracranial berry aneurysms often occur in patients with PKD, a severe headache with or without neurologic or vision changes requires attention. Please review Chart 67, Key Features of Polycystic Kidney Disease. Ultrasound is used to provide initial screening for PKD. The definitive diagnostic test is an MRI. CT scan with angiography may be used to assess kidney perfusion. Urinalysis may show proteinuria, protein in the urine, which indicates a decline in kidney function and impaired elimination. Hematuria may be gross or microscopic. Bacteria in the urine indicates infections, usually in the cyst. As kidney function declines, serum creatinine and BUN level rises. With further decline, creatinine clearance decreases and the GFR is low. Currently, no treatments are effective in extending kidney function in PKD. Supportive interventions for PKD include management of hypertension, management of pain, reducing complications from infection and constipation, and slowing disease progression. When the disease progresses and the kidneys no longer function for waste elimination, Care becomes similar to that needed for the patient with end-stage kidney disease. Blood pressure control is necessary to reduce cardiovascular complications and slow the progression of kidney dysfunction. Initially, patients with PKD may have salt wasting and should not follow a sodium-restricted diet, but as the disease progresses, sodium retention can occur, and restricting sodium may then help to control blood pressure. Achieving a blood pressure goal of 120/80 slows kidney growth from cyst formation and sustains kidney function. The most effective antihypertensive agent for PKD is ACE inhibitors. These drugs also help control the cell growth aspects of PKD and reduce microalbuminuria. ACE inhibitors can cause birth defects and are contraindicated during pregnancy. Teach the patient and family how to measure and record blood pressure. Help the patient establish a schedule for self-administering drugs, monitoring daily weights, and keeping blood pressure records. Work with the patient and dietitian to develop strategies to manage sodium and other dietary issues contributing to hypertension. Because PKD-related pain is chronic, a multidisciplinary pain management approach is helpful. Drugs may include opioids along with acetaminophen. NSAIDs are used cautiously because they can reduce kidney blood flow. Aspirin-containing drugs are avoided to reduce risks of bleeding. Complementary therapy includes positioning and the application of dry heat to the abdomen or flank. Teach patient methods of relaxation and comfort. When pain is severe, cysts can be reduced by needle aspiration and drainage. However, they usually refill. Fever, abdominal pain, and either leukocytosis or serum markers of inflammation, such as ESR or CRP, may be associated with cystic or systemic infection. Blood and urine cultures may or may not be positive with cyst infection. Early infection management can prevent or reduce complications in acute kidney injury. Monitor serum creatinine levels because some antibiotics are nephrotoxic. Percutaneous or surgical drainage of the cysts may be indicated. Teach the patient who has adequate urine output to prevent constipation by maintaining adequate fluid intake, generally 2 to 3 liters daily, maintaining dietary fiber intake, and exercising regularly. Explain that the pressure on the large intestine may occur due to the large size of the polycystic kidneys, and that can lead to constipation. Advise the patient about the use of stool softeners and bulking agents, including careful use of laxatives to prevent chronic constipation. Early in the disease, when the patient has hyperfiltration with decreased urine concentration, nocturia, and low specific urine gravity, urge them to drink at least 2 liters of fluid daily to prevent dehydration, which can further reduce kidney function. Hyperfiltration may persist for several years. Maintaining adequate fluid intake can reduce the vasopressin release that reduces kidney blood flow. As the disease progresses, protein intake may need to be limited to slow the development of end-stage kidney disease. Help the patient and family understand the diet plan and why it's prescribed. Work closely with a dietitian to foster the patient's understanding. Strategies for kidney protection include the use of a vasopressin-suppressing agent, such as tolvaptan, to improve blood flow, slow kidney volume growth, and sustain kidney function.